Okay, we'll get started. Hi, everyone. Welcome to the webinar. We'll get started in just a moment. Welcome. Thanks for joining us today for this webinar in the Pathways to Prevention series. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health and Director of Outreach with the Injury and Violence Prevention Center. Today's session is entitled Healthy Outcomes from Positive Experiences, and we'll be learning about an approach that demonstrates the formative role of positive experiences in human development. So I'll introduce our speaker in just a moment, but a few items before we get started. First, to share that this series is a partnership between the Injury and Violence Prevention Center and the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. Both of our sponsoring organizations are based at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. And as we gather, we acknowledge that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. The Pathways to Prevention webinar series is designed to connect prevention workers with the latest science on protecting children and ensuring well-being of families. We offer these free monthly webinars for those working in public health organizations, social services, child welfare, and the nonprofit sector. And during these sessions, you'll hear from researchers working on a variety of different topics in the primary prevention of child abuse and neglect, as well as adverse childhood experiences and related topics. They're held on the third Wednesday of the month at 11 Mountain Time, and we record these sessions. Today's session is being recorded, and we'll also have a link available for the slides from today. I'd also invite you to register for our April session. We'll be hosting Warren Benford, who's an international children's rights scholar, and she will be presenting on preventing digital harms in childhood, a global policy update. And I'll share that registration link with you all in the chat. Also, at the end of the webinar today, you'll be sent to a brief feedback survey. I hope you'll take a few moments and share your feedback on the webinar today. It really helps us plan future sessions to get your feedback. So before I introduce our speaker, I'd love to see who is joining us today in the audience. So if you'll open up the chat box and chat to everyone here, share your name and your organization and where you're joining us from, that would be great. Hi, Peter, Emily. All right, I'm seeing those starting to come in. Utah, Florida. Wonderful. Great to have you all here with us today. Thanks so much for sharing where you're listening in from. So I'm going to introduce our speaker today. Robert Sege is a pediatrician at the Floating Hospital for Children at Tufts Medical Center and a professor of medicine at Tufts University School of Medicine, where he directs the Center for Community Engaged Medicine. Dr. Sege is nationally known for his research on effective health systems approaches that directly address the social determinants of health. He's a senior fellow at the Center for the Study of Social Policy in Washington and serves on the board of the Massachusetts Children's Trust and Prevent Child Abuse America. He has served on the American Academy of Pediatrics Committee on Child Abuse and Neglect and on its Committee on Injury, Violence, and Poisoning Prevention. He holds a PhD in biology from MIT and an MD from Harvard Medical School, and he lives in the Boston area, although he's joining us today from Arizona. Thanks so much for being here to share your work with us, and I'll turn it over to you.
Great. Thank you so much for inviting me, Sarah. It's really a delight. Today, I'm going to talk about growing hope, or healthy outcomes from positive experiences. Let's see. There you go. So in particular, I'm going to talk about preventing child maltreatment by growing hope. And I don't have any conflicts of interest if you'd like to give me conflicts of interest. I'll be available afterwards. The objectives of the day to list the building blocks of hope, to describe new data supporting healthy outcomes, and describe at least one way to apply the hope framework in your own practice. So I want to start by saying that this is a wonderful combination of the Kemp Center and the School of Public Health of Colorado, specifically looking at injury prevention. And for those of you who are injury prevention professionals, you'll be familiar with the Haddon matrix, which looks at the person, the agent, the environment as causes and thinks about them pre-event, during the event, and after the event as ways to prevent injury and disability. Originally developed for automobile crashes, but clearly involving us. And this unauthorized snip from Carol Runyon and Des Runyon's book looks at the Haddon matrix for child maltreatment deaths. And I just want to point out that most child abuse results when parents lose control. And the person risks from the child's point of view are often normal problematic child behaviors, like babies crying, or toilet training, or oppositional behavior from teenagers, all of which are completely normal and expected child behaviors. But the agent or the parent may be at risk from family stress, mental health, substance use, or other problems that allows them to be a little more hair trigger than they ordinarily would be. And when you think about it that way, the environmental risks for the parents are both social and physical. And this is, I'm not doing justice to the Runyon's work, but I want to put this in the framework of injury prevention. I'm going to start out today by presenting what might be a paradox, or might seem to be a paradox. During COVID, or particularly the first part of COVID from March to September of 2020, where we have the best data, the risks were up and maltreatment was down. And I'm going to provide you with some evidence about why maltreatment is down. But I think everyone on this call is probably really familiar with the incredible dislocation, disruption in employment, in schooling, in social networks that happened due to the pandemic and the public health response. So clearly, risks were up. But why do I say maltreatment was down? The simple reason is because it was. So one way to look at child maltreatment is to look at reports. And there's obviously a lot of issues about reporting, which I'm not going to go into today. But just to note, the child maltreatment reports to state child welfare agencies fell more than 50% after March 2020. And the reports fell from all kinds of reporters, neighbors, police, doctors, all kinds of people, educators, of course. And the initial report said, of course, reports are down because educators aren't seeing children anymore. That was true. Educators weren't seeing children anymore, but reports from the education sector account for about 20% of all child abuse reports nationally. Clearly not sufficient to drive a 50% drop. So reports dropped. Reports obviously subject to some concern about how accurate they are. So let's look a little further. And this is data from the Center for Disease Control. And it was published by them in, I think, in December in a different fashion. And Elizabeth Sweeto at CDC was kind enough to provide me with the raw data so I could make this little graph for you. And what it shows is you can see in the period prior to March 2020, overall, and that's the top gray line, the other lines are different colors are different age groups. Overall, US emergency departments saw around 1,000 emergency department visits for child abuse and neglect from 2018 until March of 2020. Then in March of 2020, this dropped to 400 in March and only gradually recovered. But by the end of this period, which was August 31st, 2020, it was still 20% below the normal number of children who were brought to emergency departments for evaluation for child abuse and neglect. So now we have reports are down, emergency room visits are down. And there was a report from Yale from Dr. Leventhal and his colleagues at Yale, published in Pediatrics in early 2021, looking at hospitalizations across 10 children's hospitals for abusive head trauma. And you don't have to be like a super expert on understanding these box and whiskers graphs, just to note that the mean monthly number of abusive head trauma admissions fell from a median of around 30 to 40 to around 20 during the pandemic. So now we have reports are down, emergency department visits are down, and hospitalizations are down. So 3 sets of data that show that child maltreatment was down. So risks are up, maltreatment is down, but maybe there's another explanation. And we think that part of that explanation comes because protective factors came into play. Families were less time stressed, that they weren't rushing around getting their kids from place to place, or even for many families going to work. The economic stress was greatly reduced from what you would expect in a difficult time. As you remember, unemployment insurance payments were increased. There was a stimulus check that coincidentally occurred right around March of 2020. There were eviction moratoria, and I can go on, but many federal, state, and local agencies stepped in to buffer families from the effects of unemployment and the disruption. Families, of course, had more time with their children, and we found through qualitative work that family and community networks provided support. So the graph on the right is one of many from a survey that we helped the American Academy of Pediatrics do, that asked parents about their experience during the pandemic. And this is, what was it like educating your children at home? Has it been stressful? Have there been positive? Did you grow closer with your child because of that? And then those were separate questions. So we also did a little Venn diagram to show who was both. So among those who were stressed, altogether, that was 47% of the population found it very stressful to help their children with their education. A majority of those families found that they also had positive experiences. So if you look at the 29% overlap, those are families that had both reported high stress and high positivity. And 31% of families did not report the highest levels of stress, but did report positive experiences. So overall, you can see that 60% of families reported positive childhood experiences, including 29% who reported both positive and stress. So a lot of good things were going on. The American Academy of Pediatrics has a whole webpage with a bunch of reports on it. Highly recommend you look at it. Also, there were a series of surveys with very similar results from the University of Oregon, showing how families coped with the difficulties of the pandemic. Related to child abuse, we found that use of corporal punishment was quite low in US families during the pandemic. So we want to get the word out. We think that it's really important to learn from success. So if risk factors are up, but maltreatment is down, what happened? And we published a series of reports. Reasons for Hope appeared in the American Academy of Pediatrics publication, Pediatrics. Child abuse did not increase during the pandemic, was printed in JAMA Pediatrics. And then, as I mentioned, the American Academy of Pediatrics has been publishing snapshots of the pandemic's impact on family finances, education, and relationship. So with this as introduction, I want to start talking to you a little bit about hope, or healthy outcomes from positive experiences. And what we're talking about here is child maltreatment prevention that begins with a core assumption from the science of the positive, with Dr. Jeff Lincolnmack and the Montana Institute have developed, that says the positive is real and worth growing. Positive experiences promote children's health and well-being, allow children to form strong relationships, cultivate feelings of worth and mattering, provide a sense of belonging, and build childhood skills that promote resilience. And of course, it's parents who provide these experiences for children. And as we've discussed and will discuss, parents, of course, don't work in a vacuum. So hope exists because positive experiences help children grow into more resilient, healthier adults. And we'll go through some of the data and research that supports that. But the purpose of hope, healthy outcomes from positive experience as a framework is to make sure that those of us who provide services to children and family better understand and support these key experiences. And this is sort of in contrast to the current state, where currently many systems focus on the negative. For example, at intake, or when you show up at a healthcare facility, or if a home visitor comes to your home, there are a lot of screening tools, and they're all focused on risk factors, things like domestic violence and drug use and poverty. And what we find is that these screening tools, in addition to identifying risks, also can codify implicit bias and create among both the participants and the providers a presumption of deficit among the people whom we're serving as participants or clients or patients. What we're doing with hope, though, is shifting the narrative. We're looking at people because, as defined by their strengths as well as their challenges, and creating a presumption of strength. Because after all, these families have done a lot positive to get to where they are. So skipping to the science for a minute, and Sarah, I can't see what they are, but I see that there are some questions. Is this a good time to interrupt me and ask a question before I go on?
Sure. We did get one question that came in from Jennifer about the COVID data, saying that domestic violence arrests and murders increased during the past 2 years. How do you see that coinciding with child abuse rates falling? So different forms of violence. Do you want to speak to that now?
Yeah, we found the same thing in our surveys. Domestic violence rates did seem to be increased during the pandemic, and usually the two of them track together. In this case, they don't seem to have tracked together. I don't have an instant explanation other than to note that although domestic violence is a risk for child abuse, it's not the only risk. And it goes to show that even things that we think of as being very closely correlated aren't always correlated. More specifically, I think that child maltreatment happens often when families face economic or relational stress. And they lose it when a child has normal problematic behavior. So families are able to protect their children if those fundamental stressors other than domestic violence are decreased. So it is also a paradox, and I'm not an expert on domestic violence to know why that might have increased, even though children appear to be protected. I should just note that incidentally, what we found is that corporal punishment has declined in the United States. So to the point that when a provider finds out that a child is being spanked, the risk of there being domestic violence in that home is extremely high, I think if I remember correctly, over 50%. So it used to be that where there was domestic violence, we look for child abuse, and now corporal punishment has declined enough that where there's spanking, we need to look for intimate partner violence. Complicated world, ever changing. I wish I had a very simple answer, but that's the best I can do.
Great, thank you for that response. That's the only question at this point, so I think you can.
Okay, great. I'm just going to stop here. I'm going to stop periodically and answer questions, so please type them into the Q&A, and Sarah will hold on to them and talk to me about them, and hopefully there'll be time at the end for more discussion. So going back to the slides, we developed the positive childhood experience scales based on a 2015 population study in Wisconsin, part of the behavioral risk factor surveillance system, which already included an ACEs module. We also asked about positive childhood experiences and correlated these with mental health. And I just want to call out that Jennifer Jones, who's now Prevent Child Abuse America, Bart Klicka, who's also now Prevent Child Abuse America, Jeff Lincolnback, and Christy Bethel, and Peter Pecora were also involved in this work that I'll be presenting. So the scale was developed from something called the Child and Adolescent Resilience Measure, developed for the World Health Organization by a man named Unger in Canada. And the 7 items were: recalling yourself as a child before you were age 18. How often did you feel able to talk to your family about feelings? Feel your family stood by you during difficult times? Enjoy participating in community traditions? Feel a sense of belonging in high school? Feel supported by your friends? Have at least 2 adults other than your parents who took a genuine interest in you? And feel safe and protected by an adult in your home. So anytime these were answered, always or almost always, you got a point, and that points added up. You can have a positive childhood experience score of 0 to 7. And here's what we found. It was kind of astounding. So people who had 6 or 7 of the 7 possible positive childhood experiences, 87% had good mental health. Those with only 0 to 2 had a 51% chance of good mental health, and there was a dosage effect. So those of the middle number had a middle prevalence of good mental health. And I just want to say I'm using good mental health quite loosely. Specifically, in this graph, it's just those not reporting depression or poor mental health as adults. And now we looked at those people who had 4 or more ACEs. And ACEs are adverse childhood experiences. There are 10 of them altogether. There's several kinds of physical, sexual, and emotional abuse, emotional or physical neglect, and 5 kinds of family dysfunction, ranging from divorce to drug use at home. So among those Wisconsinites who had 4 or more classes of adverse childhood experiences, if they had 6 or 7 positive childhood experiences, 21% of them also had depression or poor mental health. And among those people who had high ACEs, if they only had 0, 1, or 2 PCEs, 60% reported depression or poor mental health. So clearly, positive childhood experiences mitigate at least the mental health consequences of ACEs or adverse childhood experiences. We're now working together with Elizabeth Sweeto at the CDC and others, analyzing data from additional states that have also added PCE data. Those states include Kansas, South Carolina, Missouri, and one other state, Idaho. And those are in process, and Utah will be out next year. So hopefully in the future, we'll have more data that can explore this in more detail, both with larger sample sizes and with more demographic variability. So what exactly are those childhood experiences? Well, I talked about PCEs from the point of view of a survey. I'm going to switch to work that Charlene Harper Brown and I did that looked at what are the kinds of experiences that children have that promote resilience. And this was done through a technique called a realist review, where we looked at a bunch of programs and interventions that were demonstrated to improve childhood outcomes. And we looked for what were the common elements in those programs, in particular, narrowing down on what were the common experiences that participants had. And we found that there were 4 kinds of experiences, which we've now called the building blocks of hope. So relationships with other children and other adults through interpersonal activities, safe, equitable, stable environments, social and civic engagement, and emotional growth. So I'm going to just go through these in a little more detail. Relationships. So relationships, safe, stable, nurturing relationships with other children and adults, which happen through interpersonal activities. So for all of us, our first relationship, of course, is with the person who gave birth to us. And then very quickly with our primary caregivers. And then as we get to become toddlers and be aware of our peers, that's the beginning of peer interaction, which becomes, those relationships become extremely important through grade school and high school. And we also mentioned briefly that having another adult, a mentor, a relative who's not one of your caregivers, who really cares about you, those relationships are also extremely important. The second building block of hope is the environment. Children need safe, equitable, and stable environments for living, playing, and learning at home and in school. So if you think about children, children are curious, they explore, they try new things, and they need to have an opportunity where they feel safe and comfortable to express that curiosity, to ask questions either physically as they're jumping up and down to see how high they can jump, or asking their parents how and why, and all those questions or conversations, or learning about their abilities through sports or whatever it is. But those require an environment where the child feels secure. Safe, stable, and equitable environments has two components. One is a physical environment that's safe. Is there a roof over your head? Is there enough food on your table? All those social determinants of health. The second is an environment that's emotionally safe. And I think the best one to think about here is all the work in schools to create positive school environments where the principal teaches the teachers, treats the teachers well, the teachers work well together. All of those things create a positive school environment in which children thrive. And so those things create an emotionally safe environment, whereas a famous educator said, children experience school as family, not factory. So think about both of those two components of what is a safe, equitable, and stable environment. The next building block of hope is engagement. And I have to say that Charlene Harper Brown was less surprised than I was to see this. But what happens is that children not only have to feel safe and secure, they need to feel that they matter. And so engagement, whether it's helping around at home with chores, even a toddler can help sort of with the new baby at home, school, chores in the classroom, all those sort of things. And then as teenagers, feeling like you're part of a team, a sports team, a choir, a group that's doing politics or art, or even a group that's playing games across local networks. All of these things, if you don't show up, it matters. And children need to develop a sense of belonging and connectedness. And just want to shout out that the logo, which is in the upper left and bottom right corner of the screen here, was developed for us by a group of Boston Public School artists who worked in an environment called Artists for Humanity. And they're paid for their work. And those kids actually thrive, even though they enter the program often because they're the kids who aren't paying attention in class and instead they're doodling. Someone notices their strength and it's an awesome organization to work with. Emotional growth. And emotional growth happens mostly through playing and interacting with peers for self-awareness and self-regulation. Obviously, some kids have trouble with this and need more support. And the icon here shows children playing. If you watch 5-year-olds play, you can often see, oh my God, they're just fighting like old married couples, discussing the rules. What they're actually doing is what a psychologist calls developing a theory of mind, which is that the other person experiences the world differently than we experience it, and that their viewpoint is also valid. I want to say this was done with a retrospective work. There was a recent article, it's actually still in press, published online ahead of print in JAMA Pediatrics by Guo et al. From Australia. And they set out to measure positive childhood experiences, testing the structure and predictive validity of the healthy outcomes from positive experiences framework, which we didn't know about till it was published, but boy, are we delighted. And their conclusions were the study used the HOPE framework as a foundation to develop population-based measures of PCEs, and they found the 4-factor model is an empirically valid structure. The way that their study worked is they had 5,107 Australian children born in 2004. Positive childhood experiences were measured 5 times during childhood, and health and well-being were measured at age 14 to 15, specifically looking at mental health and academic skills. In defining the measures, these are the survey items they used that correlated with safe, stable, and secure relationships, safe and equitable environments to live, learn, and play, and opportunities for engagement. And you can see they had multiple survey items for each of these three measures. And what they found, and I highly recommend actually reading the paper, is that positive childhood experiences protect against poor mental health at age 14 and 15. So you can see there is a drop in the poor mental health outcome for those who experienced positive childhood experiences at age 0 to 1, at age 4 to 5, at age 6 to 7, at age 8 to 9, or age 10 to 11. And overall, children who had positive experiences anytime in the 0 to 11 age group had improvements in their mental health at age 14 or 15. And so I'm going to pause again and see if you can, I see a couple more questions popped up.
Yeah, thanks. We do have a question. It's going back again to the COVID data. Some skepticism, I think we've all heard, and there was a lot of concern at the start of the pandemic that it was really that kids weren't in school and that they weren't in front of mandated reporters during the pandemic. And so Aaron asks, isn't it true that just the reports went down, not necessarily the actual occurrence? And I know you shared some data about the proportion of the reports that were coming from educators, but how would you respond to that question?
I'm so glad you asked, because I've gotten a lot of comments like that, because I think all of us child abuse professionals expected there to be an epidemic of child abuse. So we had reports that went down much more than you could explain by the virtual absence of reports from the education sector. So the education sector for the past decade or so has been responsible for about 20% of reports, and reports plummeted by about 50%. So education can contribute to the loss of reports, but it's not it. And we think that a loss of reporting wouldn't explain all the medical things we found: decreased emergency department visits and decreased hospitalizations for abusive head trauma, both of which were substantially down and can't be explained by an absence of reporting, particularly the abusive head trauma for children. And on the other hand, we had the surveys from parents talking about what strengthened them and what they did for their children. And I think the thing that got me started on this is listening to people say the child abuse went up, even though the data didn't show that, and they had explanations why the data might show it, and then instantly flip to what happened in their own families and what they were doing with their small children. And in talking with a bunch of people around the country, including pediatricians working in very poor communities, it turns out that these heartwarming stories were not limited to people who were not poor or who were wealthy. That other people had similar heartwarming stories about how they had gathered around to protect their children. So I think that all of the data points towards there being a decrease in child abuse. And I think it's a mistake to discard the data. And the reason why it's important, and we'll get to this in a moment, is there were policies and systematic efforts that protected families during the pandemic. And we need to learn in child abuse prevention that these data add to a bunch of other data that providing family support is the way to reduce child abuse. And if we pretend that all the data is wrong and we know better, then we miss the point and we lose the opportunity for more effective prevention. And so are there any other questions?
Wonderful, thank you. Yeah, we also have a question from Priyanka. Was the increased amount of time spent at home during the pandemic correlated with higher positive experiences for children?
It's really hard to know because, of course, we didn't do the COVID survey before COVID, so we don't really have a baseline. But families did report that they were spending more time with children, and we're currently doing a qualitative analysis of what parents said helped them and what they said were problems for them during the pandemic. And having more time with children, in particular, having less scheduled activity, is one of the themes that's emerging from that qualitative analysis of the responses from these 9,000 parents.
Wonderful. That's great. Well, look forward to learning more from that work. A follow-up question related to that, noting that there was an increase in social anxiety in youth as a byproduct of the lack of in-person and social activities, like at school. Do you see this impacting the ability for children to have positive experiences?
Yeah, there is absolutely a child and youth mental health crisis. The data I talked about was really talking about child abuse at the beginning of the pandemic. And I think particularly for teenagers and young adults, the loss of social connection has been difficult at best. And if you think about it, how many opportunities do they have to genuinely engage? They couldn't sing in a choir. They couldn't play sports. They couldn't even get together to do anything else, really. And it was troubling. I think we're going to have to use these positive experiences to help re-engage young people, in addition to treating the mental health problems for those with diagnoses, to really go out of our way to engage young people in learning from the pandemic and making them feel as if they matter. There's also, of course, a lot of anxiety around school because children basically lost a year of schooling. And talking with teachers, two things happened. One is that their reading, writing, arithmetic didn't improve the way it should have, but also children got out of the habit of social interaction. So when I talk with teachers, it's very common for them to say that their fourth graders are behaving like second graders. It's simply because you learn all of those interactional skills through interacting. And I think there's going to be a lot of catch up to do. Those are great questions. Keep putting the questions in. I will keep stopping to get to them.
Great, thank you.
So I'm going to go back to here. So bottom line, we think that the paradox of the risks are up and the maltreatment is down wasn't really a paradox, but really represents positive experiences, and that families are resilient and policy helps. So when we talk about hope, it's a strength-based, child-centered, family-led innovation around promoting access to the 4 building blocks. And as the last question just alluded to, there are things that we can do using this building block framework to help children heal. And for those, I don't know who's on the call, they're mental health people, but there's something called post-traumatic brain growth. And during that period, after suffering from trauma, which we're certainly seeing now, as we recover, relationships become more important. We develop more of a sense of awe, and there are actual physical changes in our brain. And we can create opportunities for children and youth to have those experiences that help with recovery. So I just want to talk for a minute more about hope and the dissemination of innovation and how that works and what we're doing. Because one important public health approach is knowing something and being able to count is really important in public health. But if you actually want to influence people and affect the injury outcomes, we need to actually reach people. So the way we work, we're a small team. There are 7, and as of I think yesterday, now 8 people involved in the HOPE team, pretty small. But the way we work is we collaborate with families, communities, researchers, and policymakers so that we help individuals and particularly organizations achieve their own missions. So we work with children and families, allied organizations, service providers, other researchers. I hope many of you on this call find yourself in one of these categories and want to work with us to figure out how we can use the healthy outcomes from positive experience framework to improve outcomes for kids. For example, I mentioned the survey we did with the American Academy of Pediatrics. They have 65,000 pediatrician members. The other parts of that partnership are Prevent Child Abuse America, which has chapters all around the country, and of course the CDC, working with the people who look at early childhood issues like ACEs. And so by doing that, we're able to help them do their work, but to apply the hope framework to it. So we reach a lot of people that way. And we're finding that this is working. People are taking this up. I mentioned the group in Australia that did the longitudinal survey, the analysis of the longitudinal survey of Australian children using the hope framework. Government-wise, this is a proclamation from the governor of Kansas. And she declared last week, Hope Week. It was part of what we had the Hope Summit then in Kansas, and the Kansas Children's Trust and the Kansas Children's Service League have been real allies in bringing this message out. In West Virginia, all home visitors are receiving Hope training now. Similarly, in some counties in California, the county agencies that hire home visitors are requiring hope-informed care for those patients, for those clients as young families. In Massachusetts, we're working with 2 state agencies about spreading hope in our state. California and Maine each have what they call resilience building networks, and we're providing technical assistance to them. So this is one way of disseminating innovation. We don't prepare large public service messages, but we do work with organizations that reach providers and reach the public and provide key services for them so they can use their own skill, wisdom, and reach to disseminate this particular innovation. We're also setting up our own networks. We have a national advisory board. If you go onto our website, we have unbelievable people who have joined us. And trust me, they are very helpful. They don't they don't couch their criticisms. They tell us when we get things wrong. They help us get things right. They've been extremely useful. They've been meeting quarterly now for over 2 years. We just launched what we call the Face of Hope, which are family and community experts. And these are individuals and local community-based organizations that have experienced some of the adversity and inequity and racism that we're talking about. And they're just forming that they're going to be a partner in all the materials we create and all the approaches that we use, so that we have not just the providers, but also participants and clients. Well, we are now in our second round of the Hope Innovation Network. These are learning collaboratives using quality improvement techniques to implement hope together. The current round, the Hope Innovation Network 2, is focused on assessment and intake. We put out a call for organizations who wanted to join us. We had budgeted for 5. We had 24 applicants, and we currently have 11 who are in this current round. And these are organizations around the country in multiple sectors: after-school activities, early childhood education, home visiting, healthcare, probably forgetting something, so that they're working on how they do intake and assessment so they can add to the trauma-informed assessment positive childhood experiences assessments. And we have a lot of tools and resources available to them as they do their own quality improvement projects to look at their own policies and improve them. And we partner with organizations around the world to help them fulfill their own missions. We're now working, in addition to organizations in the US, we started working a little bit in Canada, and we have a deepening relationship with the Western Sydney University, Western Sydney University in Australia. So there's a lot of really, really bright people who are working very hard and very effectively with children, but see that this kind of systematic effort to identify, honor, and promote positive childhood experiences can really transform the way we care for children, and ideally, and we hope when we're monitoring, lead to better outcomes in addition to the decrease in child maltreatment that we've talked about, that we think comes from policies. So we want to work at all of those levels, and it has been just tremendous to be able to catalyze change by putting out a framework and then asking people to apply that. I just want to go back 1 second to this slide. So one thing about this slide is there are 4 buckets of building blocks: relationships, environments, engagement, and emotional growth. And what we try to refrain from doing is providing prescriptions or even in many cases, specific examples, because we're aware that culture and circumstance vary around the country and around the world. So as we use this, we ask people to fill this in for what it means to them. And those results have been fantastic. And we're using that as a springboard. We have an anti-racism toolkit, a springboard to include cultural humility in all the things that we do, because these principles align with the work of the positive Indian parenting approach from the National Indian Child Welfare Association, who we just started to work with, as well as groups around the world, because these things are large enough buckets that you can put the culture and the wisdom and local knowledge and circumstances directly into it. And I think that it's very important that we resist the temptation to put our own experiences and honestly our own judgments and to put those on top. I'm sorry, I want to stop for a second and see if there are any additional questions.
Yes, thanks. We have a question from Sammy. If we could add 1 or 2 questions to our assessment and intake process tomorrow regarding positive child experiences, what would you suggest?
Perfect. Thanks so much. And if you look on our website, we have something, it's also on the American Academy of Pediatrics website. It's called 4 Ways to Assess Positive Childhood Experiences. So I'm going to highlight what they are, and then I'm going to give you my favorite one for tomorrow. So the 4 are the Positive Childhood Experience Scale that I described, a similar yet different scale from California called the Benevolent Childhood Experience Scales. And those are both checklists or questionnaires that families can fill out. In 2 clinical practices, one in Maine and one in California, they've taken the 4 building blocks and made kind of attractive worksheets where children and parents can fill in the blanks, and they use that as a way to begin conversations. So they have questions about what makes what relationships are important, where's your favorite place to be, what kind of things do you do together as a family with your community or spiritual home or whatever, and then something about emotional growth, and then parents and kids fill that in. And the one that, I don't know what field you're in, Sammy, but the one that I think is the most important to do tomorrow is to ask people about when they overcame a challenge. Like, can you think of a time in the past, I don't know, month, year, when even for a few minutes, you overcame the particular challenge we're talking about? Or more generally, tell me about a time when things went well for you. And these are both questions that are borrowed from the school psychology called narrative therapy. And if you ask people to tell you about something positive, 2 things happen. One is that it validates their experience. And the second is that you can then begin to point out to them the relationships, environment, social connections, all of those things that made it possible for them to succeed, and then work with them to tap on their own strength and stamina to conquer whatever problem it is that they're facing today. And these are all really powerful techniques that hopefully you can use tomorrow.
Wonderful. Thank you.
So Sarah, are there more questions, or should I go on and leave more of a question and answer period at the end?
No other questions at this time, so why don't you keep going? Okay.
So please keep those questions coming. I mentioned we have a lot of resources. Our website is called positiveexperience.org. We have, as I mentioned, an anti-racist framework in action, and we choose 2 particular examples. One, school discipline policies, and the other, treatment of asthma. So we chose them from different spheres and sort of played out how systemic racism affects those outcomes and how using community-based positive approach, we can help with that. We have, the top is our online education program. It's 5 modules, each of which takes about 20 minutes to complete. You can get CEU or CME credits for completing it, and it brings through the entire HOPE approach, including activities about how to put it in practice. And it's the other thing that when we do workshops with people, we spend a great deal of time talking about in their environment how you would do it. Today's obviously a higher level, more 35,000 foot view. We have English and Spanish information that you can post about the building blocks of hope. We have 10 ways for families to create positive experiences for children. We have stuff for educators, and we have more and more material. I just want to mention that any material that you want, there's some in Spanish already. If you like it translated, just send us a note, and we have the funds to do a proper professional forward and backward translation into any language, and we're doing that on demand. So just let us know. And when we work with organizations, we find that a lot of people already know about positive experiences, either through hearing about it or just because that's part of their culture and cultural wisdom. So we begin by asking the organization members at that workshop, where are you? Are you a sprout, just thinking of it, a seedling, a tree, flowering, or even already bearing fruit? And we're using this both to help people understand that their own work is always at least a sprout. And for those that are bearing fruit, we're unabashedly harvesting what they've learned, so that we can use that to create new materials and new approaches to creating positive childhood experiences. So what's next for us at the Hope National Resource Center? We're increasing knowledge of the effects of childhood experience. I mentioned the research we're doing with the CDC about national surveys. We're also working with APHA, doing a systematic review of literature. We love being able to learn from people of different cultures and experiences what positive childhood experiences means to them. And it's been enormously enriching for all of us, and hopefully as we provide that information through our website and other ways to other people too, to realize that there's so much going on that fits this, and that maybe hope goes back to an ancient cultural narrative, and the idea of screening and referral has been added on to that, but we're tapping into a really deep stream. And as we work, we've been appreciating the wisdom and dedication of the providers and leaders we've met and worked with. And early on, we talked about how we needed to change the mind or the mindset of the providers, and we've stopped talking about that, because as we've heard from people, many individuals and organizations are already doing this, and they feel almost like, I don't know, maybe it's a little underground activity, or they're a little radical, but they're doing it. We don't have to change their mind. We have to change their policies and procedures to go back to the spirit that they entered the work in. So this is an injury prevention oriented group. So I encourage you to learn a little bit from what we did at Hope to dig deeply into the causes of injury. And of course, the Hatton Matrix provides a way to do that, because there's what happened before the injury. And in particular, what are the environmental causes? And so we know for automobile crashes, for example, that building safer roadways and safer cars, decreases car-related fatalities much more dramatically than, for example, telling people, even trying to teach them to be a safe driver. So the environmental causes, they may be surface level, they may be deeper. And today we talked about the economic stress on families and how policies that relieve that can reduce child abuse. Another classic example from our field is when they first introduced paid parental leave in California, deaths from abusive head trauma declined 6%. So none of that was about teaching parents not to shake their baby. There was no psychoeducational approach. It was just realizing that when a baby is born, among the other things that change in the family, there's big economic stress, paid family leave, which is now being built up around the country. And that's an example of building solutions that begin with the positive. In our case, families really, really, really do want to protect their children. They love them. They give their children everything. And creating solutions to issues like child abuse that begin with that seem to be more effective than solutions that begin with educating them with the knowledge that we have. I think in general, my personal thing is that once you started down the us and them approach, you've kind of lost. We invite each of you to join us in the Hope Transformation. Our website, positiveexperience.org, has a lot of materials. We have blogs. You can watch our videos. We have, for example, examples of people doing screening for depression and drug use using a hope-informed approach. We have an online course that teaches hope from beginning to end. Love for you to share with your colleagues, ask your partners, and if your partners are your patients or clients, that's fine. If your partners are your funders, that's fine too. But tell them about this and the stuff we published and the stuff that's on our website. And just responding to the last question, think about how to build hope into organizational logic models, how to prevent maltreatment through policy supports. And when we're doing analyses, to resist the temptation to divide the world into us and them, and you can put whatever names you want around the us and them or that sort of thing, and realize that child maltreatment results from a failure of parents to be able to do what they want to do best, which is love and protect their children. And so how do we address the issues that prevent them from doing that, and think about our own experience as children or parents, and use a more empathetic approach to understand that. So I want to just really thank you for your attention. I can see there's at least one more question. Let me try to answer that. And then you can obviously reach us. Our email address is hope@tuftsmedicalcenter.org. Sarah, do we have time for one more question?
Yeah, appreciate your presentation. One additional question is, are there opportunities for graduate students to get involved in the work of hope?
Oh my gosh, there sure are. Please send us a message, hope@tuftsmedicalcenter.org, and we'll get right back to you. We have more data, more things to do than you could imagine. And we've also been very happy to have graduate students who are doing their own work and who just want a little tech support or something from us for what they've already decided. So I think this summer we have 4 grad students working with us. We have where we'd be delighted to work with anybody anywhere who wants to apply this to their own work.
That's fantastic. Well, thank you.
I love that question.
A great closing question. Thank you for sharing this with us and for all these great resources. And as I said at the beginning, we'll send a follow-up email to all the registrants with the recording and the slides and the link to the Hope website if you'd like to get more involved. But thank you all for listening today. And thanks again, Dr. Sege, for joining us.
Great. Thank you. Thank you for inviting me. And thank you all for the work you're doing to reduce childhood injuries.
Bye.